Assalamu alaikum, colleagues and friends. I want to greet you with the Assalamu alaikum, and then good day for you anywhere. If you are if you are listening, this is in the morning, then good morning, and if somebody is listening in the evening, so good evening. So first of all, this video I want to present because this video or this topic is not a very common topic, and in my opinion it's a very important topic in that regard for the continued medical education, or in the recent time we can say there are some we can say the modifications in the neurosurgical treatment for few kind of the problems which were dealt previously not appropriately, and now in a current scenario we are dealing in a very good manner, or vastly we can say. The topic is the carotid-cavernous fistula. Definitely I want to discuss this with the one case presentation, and then definitely we would like to discuss in detail about the treatment option of this problem. As you know, first of all, I want to give the little introduction about this disease, what we can say the carotid-cavernous fistula. The carotid-cavernous fistula categorized as direct and indirect. It is categorized in the two forms, direct and indirect. The direct type are usually post-traumatic, and we can say high flow, or we can say single shunt between the internal carotid artery and cavernous sinus. But the other way, indirect one, which is low flow from the meningeal arteries, meningeal branches, and there is a multiple communication possible, or more than one communication possible, but it is the low flow. So this is the two major kind which I wanted to describe you. But there is a one Barrow et al. Barrow et al. Barrow. He has divided into four forms in the A, B, C, D, like that. And the Barrow A is considered the direct one, and the other B, C, D are considered like the indirect one. I want to present first of all that one case, the 28-year-old or 29-year-old male presented to me in the emergency room with the history of RTA, and when we saw him at the time of presentation, patient GCS around 12, patient was drowsy, disoriented definitely, and we admitted this patient moving all four limbs except the patient talking, means irregular words or not appropriate, we can say the complete words. So that's like we consider GCS 12/15. We admitted in the sub-ICU, or we can say HDU, high dependency unit, which you consider that the step down of the neurosurgery department, like that. And then the patient CT scan has been performed, and CT scan brain showed there the bilateral frontal contusion associated with the interhemispheric traumatic subarachnoid hemorrhage, and with bilateral frontal a thin film of the subdural collection, which was not causing any significant pressure over the brain and not causing any mass effect over the brain. So we treated conservatively with the help of the mannitol and conservative measure with some anti-epileptic drugs and little antibiotic, and patient has been treated without any surgery, without any intervention, and discharged from the hospital. After 1.5 years, patient presented to us in the OPD, and he is showing the congenital chemosis or congenital, we can say there is a hyperemia and corneal exposure, corneal congestion and diplopia and proptosis and intolerable bruit which we can hear on the eye or orbit. Patient also complaining of the headache. So these are the signs and symptoms of the patient, and then we did the CTA for him, computerized tomographic angiogram, and associated with the magnetic resonance angiogram and venogram, and then we recognized there is a direct connection between the internal carotid artery, right internal carotid artery, with the right cavernous sinus in that area, or you can say right part of the cavernous sinus in that area. And then we considered or we diagnosed this patient as the carotid-cavernous fistula. At that time, patient was stable and the treatment may be usually performed within a couple of days, and we try to do as soon as possible for him. And then because we have the significant indication for the urgent treatment of that kind of patient, especially sign and symptom I represented. What other indication we could consider in these kind of patient? In these kind of patient, intracranial hemorrhage, apostaxis, increased intraocular pressure, decreased visual acuity, rapidly progressive proptosis, cerebellar ischemia, and enlargement of traumatic aneurysm, which also considered for the indication of the treatment for such kind of patient, such as carotid-cavernous fistula. As you know, we treat these kind of the patient, and the treatment goal is to eliminate the fistula. As you know, our patient is the direct high flow carotid-cavernous fistula with single attachment or single connection. So it was usually treated with the definitely endovascular but via transarterial way. And in the other way, if there is a patient has a indirect carotid cavernous fistula and multiple connections, then we definitely treating this transvenous but definitely endovascular route. Angiography usually performed to identify the exact location and the size of the fistula and the venous drainage, so we can plan our treatment. To address the high flow, considered angiography at 7.5 fps instead of usual 2 to 3 fps, in addition to the carotid cavernous fistula, and which is definitely high flow, and definitely there is a vascular injury, so it is an absolute indication for the treatment or intervention. Actually, we send this patient to the center where are the neuro-interventionist or neuro-interventional radiologist and the neurosurgical team are there. With the combined team, they are working together and they treated such kind of patients. So in our patient, what happened, I definitely tell you, but what usually needed to treat such a patient, I also wanted to mention here, because this lecture is very much educated or very much informative, educative, and very much helpful for the exam or the conference presentations. Selective catheterization usually of both external carotid artery and internal carotid artery has been performed and axis their contribution to the carotid-cavernous fistula. So, the angiography is also performed after manual compression of the carotid-cavernous fistula on the side of fistula to better access and cross flow from the contralateral side also. You know, the digital compression will attenuate the high blood flow to the fistula and enabling its visualization. Usually these are the principle. On that principle we are treating such kind of patient. Do not compress the both carotids simultaneously. It is morbid for the patient, or patient may suffer some kind of injury. So that's why one or unilateral compression of the carotid may helpful in some cases. Rotational angiography with 3D reformatting may be performed to study the fistula and select appropriate working view for intervention. It is important to be cognizant of venous involvement, including cavernous sinus or superior or inferior ophthalmic vein or sphenoparietal veins or superior or inferior pituitary sinus and the pterygoid plexus. Either you involve some of them, a few of them, or one or two of them. These following routes we may utilize to treat carotid-cavernous fistula. As you know, the transarterial, transvenous and via superior ophthalmic vein, are now considered like a conventional routes, even though when the conventional routes we are using, and sometimes conventional routes are near to impossible to use. So that's why our indication, such as my patient which has corneal exposure or corneal or conjunctival chemosis or diplopia and proptosis and intolerable bruit and headaches. These were all contributing factors which may or consider us that we should go for surgery. In my patient, transarterial route was used, and this endovascular event used the coils and then over that onyx. But I will tell you about in detail about the coil, onyx, MBCA, detachable balloon and coil occlusion of internal carotid artery in bit detail, so you can understand what is the value of this and how we can use this. Coils currently the method of the choice in intra-arterial coil embolization of carotid-cavernous fistula. Using road mapping and microcatheter is advanced over microwire into the cavernous sinus via the fistula, and this may take some efforts because it is a tortuous route, but coils are even deployed and detached as previously described for the aneurysm in my previous videos. Periodic angiography is performed and further coil placed until the cavernous sinus is completely occluded. Complete occlusion is indicated by no further contrast entering the cavernous sinus. So, this is the use of the coil. So, complete occlusion is indicated when no further contrast entering the cavernous sinus. So, it is indicating that you occluded that part. And here, coilings are working very well. Sometime when the occlusion is not complete or incomplete, considered incomplete, then we are a jelly-like or gel-like drops or droplets or jelly form we can use, which is called onyx, and this onyx is preferred in the AVM for blockage we are using, but for this person's purpose we can use that. In case of high flow fistula, prior to the onyx deposition, it may be advisable to initial deposit coils into the cavernous sinus to slow down the blood flow, as it happened or it has been done in my case. Then will prevent the inadvertent embolization of onyx into the draining vein and sinuses. A balloon can be inflated within the patient internal carotid artery in order to protect it, as the onyx is being injected into the cavernous sinus, and this may hamper or cause some kind of problems. In the same manner, NBCA, which was not used in my patient, but I wanted to mention you what is MBCA doing. MBCA should be used with great caution, preferably after having slowed the flow through the CCF, or you can say carotid-cavernous fistula, in order to prevent untoward deposition in the venous sinuses. There is a potential for reflux into the carotid artery, which could cause a stroke, and this may particularly occur when the carotid-cavernous fistula closure is near completion and the pressure gradient between the carotid artery and the cavernous sinus is lowered. So as this onyx, a balloon can be inflated in the parent artery to protect it. So these are the few cares we have to do, few cautions we have to apply here. Detachable balloon, previously used vastly, but nowadays is less used because of the premature detachment and deflation over a time. So that's why ballooning is used very carefully, not everywhere. Coil occlusion of internal carotid artery, a desirable treatment. Sometime, I am telling sometime, coil occlusion of the internal carotid artery may need the desirable treatment of carotid-cavernous fistula is the occlusion of the fistula itself, essentially resulting in internal carotid artery reconstruction, and this is frequently not possible. And if the carotid-cavernous fistula is not amenable to treat, or we couldn't treat easily by any other route, so the sacrifice of the involved internal carotid artery is an option, especially if satisfactory supply has been confirmed from the contralateral internal carotid artery. If we are getting a satisfactory supply from the contralateral internal carotid artery, then via anterior communicating artery or supply via the posterior communicating artery, if we have a good supply, then we may occlude the whole internal carotid artery at that place to avoid to treat the carotid-cavernous fistula, but it is not always. In my patient, post-operative management we did like that. We admit the patient after endovascular procedure in the neurosurgical ICU for overnight observation, and further ICU stay will depend upon the patient's clinical condition. Consult for the arranged follow-up with the ophthalmic surgery. Why? Because the post-operatively we wanted that he should see if anything he wanted to do for the ophthalmic point of view. 9.9% normal saline with 20 milliequivalent potassium chloride at the rate of 150 cc per hour for 2 hours we start, and then decrease to the 100 cc per hour if the patient is NPO overnight. Keep the leg in a still position as much as possible because this procedure need 2-hour rest, and we may give rest for 6 to 8 hour manual compression over the puncture point where the femoral sheath has been placed. So this topic here, yani groin and the vitals, you have to check everything. Here I wanted to I can say I wanted to close this topic just for the regarding my case, but I wanted to add one more way of treatment which is called superior ophthalmic vein cannulation for the treatment of the carotid-cavernous fistula when it is very difficult to go transarterially, and then the routine conventional ways are difficult to access, or inferior petersal sinus, which is very tortuous, and sometimes it open aberrantly in other area and we cannot reach to the cavernous sinus, then we are considering superior ophthalmic artery cannulation. And how we are doing nowadays, it is very important and good to know as a neurosurgeon. As you know, sorry for interruption. As you know that the superior ophthalmic vein approach for the embolization of the carotid-cavernous fistula was first described over 25 years ago. And this carotid-cavernous fistula are typically divided into 4 subtypes defined by etiology and nature of the lesion. This activity describes the pathophysiology of the carotid-cavernous fistula and highlights the role of interprofessional team in the management of this patient. Objectively, actually we should know that what is the indication of the endovascular treatment of carotid-cavernous fistula? Simultaneously, relevant orbital anatomy for superior ophthalmic vein cannulation and surgical technique to dissect the orbit and identify the superior ophthalmic vein safely. And we want to outline the interprofessional team strategies for improving care coordination and communication to enhance the treatment of the carotid-cavernous fistula and to improve patient's outcome. I want to introduce this thing, especially the superior ophthalmic vein approach for embolization of the carotid-cavernous fistula was first described over 25 years ago, as I mentioned before. Carotid-cavernous fistulas are typically divided into the four subtypes defined by the etiology and the nature of the lesion. Direct, one category is direct, which we say also Barrow A, according to the Barrow classification. And this lesion involved in the endothelial tier of the carotid artery itself or internal carotid artery itself, while indirect lesions such as the Barrow C, Barrow B, Barrow D involve small branches of the internal or external carotid artery or meningeal artery to make this carotid-cavernous fistula. These directs are usually high flow and the indirects are the low flow. Directs are with the single connection and the indirects are with multiple connections. I just wanted to bring in your knowledge the 10 to 60% of carotid-cavernous fistulas may spontaneously resolve, and up to an additional 30% of low-flow carotid-cavernous fistulas may resolve with conservative management such as carotid compression technique or carotid compression therapy, which I mentioned earlier. Many progressive lesions require interventions such as my case. Direct lesions are amenable to endoarterial treatment and indirect lesions are appropriately treated with transvenous embolization. The ipsilateral inferior petrosal sinus, it is a conventional way of access to cavernous sinus, is the preferred route, but the initial report is characterizing that these case series in which the superior orbital ophthalmic route was utilized when traditional access through the inferior petrosal sinus has been failed or we cannot find because of the aberrant anatomy. Typically, superior ophthalmic vein can be accessed through the facial angular venous system. However, the case exists in which stenosis, hypoplasia, or toxicity of the vessels prevent safe transvenous access via this route. So, surgical cut down for direct cannulation of the superior ophthalmic vein is a safe procedure, effective procedure, and effective option in these cases in which other endovascular approaches have been exhausted or cannot be done. With advance in intra-endovascular access technique, the necessity of this approach has decreased. So, still direct cannulation of the superior ophthalmic vein via surgical cut down remains an important technique in the surgical armamentarium. And this armamentarium has all kinds of the treatments such as the surgical and endovascular or transarterial or transvenous in our armamentarium, especially to treat the carotid-cavernous fistula. I want to discuss about little thing about the anatomy and the physiology. As you know, the knowledge of the orbital anatomy is crucial to avoid damaging key structure within the orbit. So, particularly once the orbital fat pad has been exposed, the superior ophthalmic vein forms at the junction of the supraorbital vein, angular vein, and supratrochlear veins within the superomedial orbit. So we have to identify this specific vein among all of these veins. It is consistently found approximately 6 millimeter above the superior sulcus of the eyelid nasally, and it present nasally, means nasal side, on the superior sulcus of the eyelid. So additionally, the superior ophthalmic vein can be identified by following the superior or supraorbital vein into the orbit. The supraorbital vein itself can be within the supraorbital notch when present, as the superior ophthalmic vein crosses posteriorly and laterally with the ophthalmic artery, which is located posteriorly and laterally to the superior obliquus muscle. So it received and draining vessel from the superior orbital structure, including the ethmoid vein, central retinal vein, muscular vein, and superior vortex vein, which is all draining into the superior ophthalmic vein. This superior ophthalmic vein crosses the anterior portion of the optic nerve and transverse and superior orbital fissure, eventually terminating into the cavernous sinus. So this superior orbital vein has also been noted to run directly underneath the superior rectus into the superomedial quadrant of the periorbital cone, a useful landmark when the vessel is not hypertrophied outside of the deep orbit. So anastomosis with the inferior ophthalmic vein is also a variable of this vein, and it is not causing any connection deficit to the cavernous sinus, which lead to us in cavernous sinus in both ways. So the indication of the direct cannulation of the superior ophthalmic vein for endovascular treatment is appropriate. For indirect cavernous sinus fistula, typical sign and symptom include pulsatile visual defect, headache, ocular and orbital pain, diplopia, conjunctival chemosis, proptosis, orbital bruit. So these all symptoms were there in my case. That's why we advise to treat endovascularly. Actually, this case I have seen with my friend, with my one of my friend, which is also my team member, in the same hospital where they did the superior ophthalmic vein cannulation for some other patient. A common association in congestion of the inferior petrosal sinus and the arterialization of the ophthalmic and orbital vein, the superior ophthalmic vein may be used for transverse access to lesion of the cavernous sinus when other routes have been exhausted or anatomically unavailable, or we cannot access them. Aberrant anatomy of the inferior petrosal sinus, in which it is exquisitely tortuous, or discontinuity with the proximal jugular system, so may make that approach impossible. In that manner, we need the superior ophthalmic vein cannulation. Access to the superior ophthalmic vein via the angular vein through the facial vein is commonly employed as well, although the small caliber of the vessel and sharp angle may make this route technically challenging. In such case, if the arterial axis is insufficient, then direct cannulation of the superior orbital vein should be employed. This was the indication of the superior ophthalmic vein cannulation. Now I want to discuss with you some contraindication of the superior ophthalmic vein cannulation, such as conservative management will lead to resolution of the symptoms in a significant number of cases, so no need of any kind of cannulation to the superior ophthalmic vein. That's why in a detailed assessment of the symptomatology in the immediate preoperative period is critical to avoid unnecessary intervention. In the same time, if thrombosis of the superior orbital vein, so we cannot use the superior orbital vein. Further intervention may not be required in that situation. Patient with the suspected direct or mixed carotid-cavernous fistula may require the endoarterial treatment, which route was used in my case earlier of this lecture, and should not be solely treated with transvenous embolization. Few equipments I want to discuss when we are doing the transvenous or or we can say superior ophthalmic vein cannulation. Standard microsurgical and endovascular equipment is required for this procedure, and this procedure can be safely performed in the endovascular suite with proper anesthesia support. It is important to have a surgical headlight together with the appropriate orbital surgical instrument which allow proper orbital exposure. So we need the C-valve retractor, ribbon retractor, and the long bayonet forceps and the bipolar cautery forceps to allow easy access to any bleeder deep within the orbit. So neurosurgical cottonoids or the surgicels are, or we can say the patties, cottonoid patties, are useful to separate the fat from the vessels, and these muscle hooks are useful to lift the superior orbital vein gently via ligation band, or the suture are applied, as the surgeon will be operating with limited mobility because of the radiological machinery, and a good assistance is very useful. As these procedures are performed infrequently, we give a list of this necessary surgical instrument to the intervention radiology department. This procedure requires a team such as the neurointerventional and orbital surgical surgeon and surgical expertise, and the procedure can be performed in angiography suite with the assistance of the anesthesia staff, and we prepare the digital subtraction 4-vessel cerebral angiography, or the angiography is the gold standard to diagnose and initial therapy of the carotid-cavernous fistula. However, even though we are diagnosing these kind of cases on the normal CT scan, with the normal CT angiography, or with the routine MRI or MRA or MRV, and we are confirming the diagnosis, if there is any doubt or there is a difference in the etiology, such as the tumor, posterior communicating artery aneurysm, or infection, so the detailed history should be obtained and the physical examination should be performed on the day of procedure to assess the necessity of the intervention. Technique of treatment. First of all, I want to here discuss the technique of treatment to you. Informed consent must be obtained, and the risk of the benefit of the operation should be explained to the patient. The patient is positioned supine in the angiography suite and induced under general anesthesia, and then after that a femoral sheath is placed in the standard fashion for angiography usually has been done. The sterile field include the eye, eyebrow, forehead, and cheek. So after all aseptic measure, especially over the eye, eyebrow, and the forehead and the cheek, and then you can apply the incision, which is the small incision is made in the medial upper eyelid crease. Alternatively, a sub-brow incision may be used, and usually what we saw they put the incision on the medial upper eyelid, and they are termed as medial upper eyelid incision, and the incision was carried down through the orbiculus oculi muscle. They used the blunt separation with the Stevens scissor, and it is important to obtain the hemostasis at the point as there be a oozing from the tissue below the orbiculus oculi muscle, which can interfere with the surgical side. So maintaining this hemostasis will help you to visualize the structure. Orbitotomy, we have to use sometime. This orbital septum is opened medially, revealing the medial retroseptal fat pad which will be whiter than the central fat pad, and this fat pad is bluntly dissected into the posterolateral direction until an arterialized feeder of the superior ophthalmic vein is identified, which is traced back until the main trunk of the superior ophthalmic vein is found. If multiple feeders are identified, the milking of the vessel may help identify the direction of the flow, and if the vessels have not significantly engorged, it has been suggested that an osteotomy may be needed to broaden the exposure to the deep orbit. Although we have not found this to be necessary in over 40 cases, according to the where we saw this case. C-valve retractor together with the moist neurosurgical quaternoid are invaluable at this stage, and if the surgeon is familiar with the anatomy of the angular vessels and the supraorbital and supratrochlear vessels, then the superior ophthalmic vein can be identified with relatively ease by following one of these vessels leading into the superior ophthalmic vein. Another maneuver that we have found useful is to use a blunt separating motion with either a hemostat or a Stevens scissor. This allows separation of the superomedial orbital sinus, which in turn will expose the dilated superior ophthalmic vein. For the sake of the completeness, it should be mentioned that some surgeons perform an additional brow incision, dissect the subcutaneous tissue and the frontalis muscle until the orbital vein or orbital rim is reached. Then they design a small orbitofrontal bone flap is made in the orbital rim. In its approach, the superior orbital vein can be identified with the superior medial portion of the periorbital cone following gentle retraction of the superior rectus. However, as the mentioned that the osteotomies can be done to increase the retraction or increase the lightening or proper knowledge of the anatomy is to determine. Simultaneously, isolation of the superior ophthalmic vein is bluntly isolated, freed from the attachment and exposed to the surface of the incision of the vessel wall. Rubber loop may be used around the superior ophthalmic vein to allow manipulation, and the vein is kept taut with these loops. So the 4-0 silk suture may also be used instead of this rubber loop. And the vein is entered with the angiocatheter, so the breast bleeding confirm a flow thickness or full thickness opening and allow us cannulation. The angiocatheter is usually tied with the suture, and the catheter is advanced to the cavernous sinus with fluoroscopic guidance using a gentle injection of the contrast through the catheter. Once the placement is confirmed, obliteration of the cavernous sinus can be performed. And using a standard endovascular technique, liquid embolic agent, coilings, NBCA, Onyx, you can use as per need, as per the expertise. Care is taken to leave one of the ophthalmic vein patent to prevent the sudden increase in the intraocular pressure, so the arterial angiography is performed to confirm obliteration of the fistula, after which the catheter is withdrawn. The superior ophthalmic artery is ligated distally to the insertion point unless it is large and the thick walled, in which case the vessel is primarily closed with the help of 6-0 prolines. The orbit may be irrigated with the antibiotic solution, then closure is started. After meticulous hemostasis is obtained, the orbital incision is closed using the simple 6-0 vicarial suture and after that follow-up angiography is recommended if there is a suspicion for recurrence of fistula, and clinical follow-up is recommended at 6 and 3 months post-intervention. The patient's vision and intraocular pressure should be assessed regularly. Few complications could happen, such as the surgical cut down of the superior ophthalmic vein is typically well tolerated, and the complications include damage to the orbital structure, is particularly the superficial veins and superficial nerves and the oculomotor muscles. Few such complications have been reported in the literature. However, during endovascular treatment, vessel rupture with subsequent hemorrhage is possible, but in one observed case of the superior ophthalmic when a vein rupture has been done, but thank God no retroorbital hematoma has been noted up till now. So the patient was successfully managed conservatively, even though this is the aggressive embolization of the cavernous sinus may lead to the cranial nerve deficit. So we have to check thoroughly each and everything. Clinical significance in that the over 95% of the patient receiving endovascular embolization via direct surgical access of the superior ophthalmic vein remained symptoms and recurrence free at the last in a long clinical follow-up. Even in setting of the incomplete embolization, clinical improvement has been observed, and the direct cannulation of superior ophthalmic vein is safe and effective approach for the endovascular treatment of the indirect carotid-cavernous fistula in setting in which other endovascular approaches have been exhausted or cannot be done. Superior ophthalmic vein cannulation for the treatment of the carotid-cavernous fistula require an interprofessional approach and coordination and conversation. It must be, because the neurointerventionalist is required for the femoral axis, then eventually endovascular treatment of the fistula. Once the vein has been cannulated, orbital surgeon is required for the surgical procedure, and trained staff can be required to assist in the interventional suite, while the anesthesia will be needed to monitor the patient. Nursing and the clinical staff can aid in the screening patient on the day of surgery to ensure the symptoms are ongoing. Pharmacists may be needed to aid with the post-operative pain management, which is typically minor in this setting. This is why an interprofessional team approach care is necessary for treat such kind of patient, as it lead to the better outcome of such kind of the patient. I hope I try to present this case in a thorough detail, and especially the superior ophthalmic vein cannulation I explained in detail. I hope you will appreciate it, and I will try to bring such kind of cases, which is very rare. I know very low audience for that, but I wanted to in a long run people can get benefit by audio visual benefit.